So first of all, thank you very much, Andreas, for the kind introduction and for the invitation. Thank you all for being here and take your time to listen to me. I mean, I highly appreciate that. Next time I'll put, instead of EAPCI secretary, Andreas secretary. So it will be much more impressive. So I think at this time of the day it will be much more productive to discuss about this topic by providing you with case examples, which is something that belongs to our daily practice. And I'd like to start with this patient, 64 years old, several risk factors, as it is often the case in these kind of patients, who presents with acute coronary syndrome, non-ST elevation myocardial infarction. We heard before whether calcified lesions can be also associated with acute events. Well, they are. And when there is this combination, and you are in the middle of the night and you cannot master on your own several techniques and tools, then you are in troubles, because then you have to wake up your colleague who's more experienced than you and try to help you out. So this is something to keep in mind. This was the right coronary angiogram performed in January this year. Perhaps the light doesn't help you to see that. I don't know if we can dim a little bit the light, because there are lots of videos here. And if you want to see the amount of calcium, we are better in the dark. Anyway, this was the right. You see some sluggish flow beyond the subocclusion there. Yeah, that's better. And this is the left coronary angiogram. So you see this patient has also a problem in the medial AD, and there is quite a good amount of collaterals to the right. I give you also this other projection, where you can perhaps better appreciate also the stenosis in the medial AD. You can already start seeing the problem there, namely that there is a decent amount of calcium. It was decided in January to treat this right coronary artery right away, as it was considered to be the culprit, the reason for instability of these patients, despite the amount of collaterals that was going there. And this lesion was treated with regular balloon PCI and implantation of 2 drug-eluting stents. This is the final angiographic result. You might be unhappy, as it is not perfectly okay. Nevertheless, they got the procedure done. Now we are left with this problem here. We need to treat the left coronary artery, the medial AD. And before sharing with you my strategy, I'd like to hear your strategy. How would be the way you would treat this patient in your practice? Who needs more information in this case and would like to know more about the hemodynamic significance of this LAD lesion? Who wants to do IFR, FFR? Raise your hand. Okay. Who believes this stenosis is really tight enough and deserves angioplasty? Raise hands. Not so many. Let me check if there are surgeons in the room. Who wants to offer a lima to the LAD to this patient? No surgeons. So from those of you wanting to perform a PCI, I'm curious to hear who would do direct stenting in this LAD. Raise hand. Direct stenting. No one. Who would do balloon PCI plus drug-eluting stent, or at least give it a try with a balloon first? Yeah, let's put it in this way, majority. Who doesn't trust the angiography, would rather go for a plaque modification? Of course, it's a question. You? Don't be shy. Raise your hand. One. Okay. I tell you what we did, what I did actually in this patient. I first of all staged the procedure. The first procedure was done by another colleague. He did the culprit, he went to sleep, and he put this patient on CCU. 1 month later, the patient came back. He was still symptomatic, referred some chest pain. During effort, ECG showed some ST segment depression in the anterior leads. Left ventricular angiogram was normal. This was my setting, radial access 6 French, ABU guiding 3.5, 6 French. As we usually do, and perhaps you do the same, at the time of the stage procedure, we tend to check the result of the coronary angiogram, of the coronary artery that we previously treated. And this is now the angiogram taken with the guiding catheter. It is a little bit better filled. So you see again the lesion there. And please look carefully at this angiogram. perhaps you can better appreciate the amount of calcium now, the length of the lesion, from where to where do our treatment, the additional challenge of the bifurcation just in our way. Let me ask you again, who would do some plaque modification first, having seen this? Raise your hand. Okay, increasing number. Good. So we know, we have heard it from the previous speakers, when we see so much calcium, we can already anticipate that the wall compliance is reduced. This will prevent the adequate lumen expansion. We know that this will predispose to ugly dissections and incomplete stent apposition, and it is associated with suboptimal outcome of these PCIs. We have heard of it. So my strategy was in this case to perform indeed plaque modification based on this last angiogram, and I wanted to be less or the least aggressive as possible, and started to do my ablation with 125 millimeter bar followed by 1.5 millimeter bar. And the intention for this bifurcation is just to do provisional stenting. Very simple technique. The more the complex the anatomy, the simpler should be the technique used, at least in my opinion. So I think those of you performing rotablator are familiar with this kind of motion of the bar. These were 2 runs with 125 millimeter bar. First run on the left, second run on the right. I guess nothing special. This is just a control shot. I just do, some contrast washout. It's not even filming, it's storing the image. But this reassures me that first, I did not cause any damage to the vessel, and second, that there is still some preserved antegrade flow. Next, as it was planned, we did 2 runs with 1.5 millimeter bar, really stepwise. Once you start doing this procedure, it is always good to have your own protocol. Stick to it in order to minimize the risk of complications. So the 1.5 millimeter bar went nicely across, and this is the angiographic control thereafter. Are you happy with this? Who would do more, would go higher in terms of bar size? Raise your hand if you're happy with that, and you would move now to balloon, or at least give it a try with a balloon. Raise hand.
You're
Who would?
6 French, right?
I'm 6 French. Who would take a bigger bar? Okay. The question of Andreas is adequate. The fact of having a 6 French in a way is already influencing the bigger size that you can use. We have prepared this consensus document a few years ago with several European experts. There is also one colleague from UK, I think you all know Adam de Belder, in order to more or less have a common ground in tackling these patients with rotational atherectomy. And we agreed that the main objective of contemporary rotational atherectomy should be to modify the plaque. So we're not anymore aiming, in most of our cases, to debulk those coronary stenoses. And this practically means smoothing the lumen in order to disconnect the calcium rings. And this is most of the time achieved with single bars or with 1.25 to 1.5 millimeter bars. What is the ultimate goal? The ultimate goal, as it is also mentioned in the guidelines, as we've seen before, to facilitate further balloon dilatation and optimally implanting the stent. That's the job that rotational atherectomy should do nowadays, if we want also to minimize the risk of complications that can be associated with this technique. In the same document, we did a number of recommendations. I don't want to go through all of them. I want to perhaps highlight a few of those who might be of interest. How to select bar size. We agreed that a good plaque modification could be achieved with a bar to artery ratio of 0.6. Pacing considerations. If you are in the beginning of your learning curve, it would be useful to have pacemaker lead for right coronary artery or for dominant circumflex, even if I'm sure that once you gain experience, you can manage those cases with a little bit of atropine or just bailout pacing. But in most of the cases, it's not really needed. Ablation speed, lots of discussion there, but we agreed that the ablation speed should be between 135 and 180,000 revolutions per minute. The run, so each run of rotational atherectomy should be as short as possible, not longer than 30 seconds in any case. Packing motion, we have seen it. Why? Because we want to minimize deceleration. So if we try to do all at once this movement, the chance that deceleration, major deceleration will occur and eventually bar stalling will occur is higher. So deceleration, if it occurs, should not be more than 5,000 RPMs. Now, these are all numbers. Once you are in the middle of the procedure, you will not pay attention to all those things. The new rotablator system, in a way, is helping the operators on this. But what is very important is to keep listening your device, because the noise is much more informative than all these numbers. When to stop? There is no recipe here that is valid for every patient. When the operator thinks that sufficient plaque modification has been achieved in order to further dilate and implant the stent. It's something easy to say, but very difficult to count, to quantify. Now, going back to our patient here, I think we all agree in this room that we would stop doing rotational atherectomy, also because we have a 6 French guiding catheter. We would move on with balloon. Let me hear your preference for balloons. Who would use semi-compliant balloon? Raise hands. Who would use non-compliant balloons? Raise hands. Who would use cutting balloons? Raise hands. None. So majority for non-compliant balloons. I agree with you. I agree with you. I think we all know this, but sometimes it is helpful to remind that. How does it work, balloon dilatation? It works by inducing barotrauma in the vessel wall, dissection. That's what we want when we use balloon. And thereafter, there might be some elastic recoil. The point is that when we use a balloon, dissections occurs, but not where we want in a calcified lesions. Dissection occurs at the point of low resistance. That is why when we use semi-compliant balloon, the chances that balloon will grow in diameter is much higher than the one that you can have with non-compliant balloon. And if it grows not where you want, not where the most calcified part of the vessel is. That is why you might have higher chance of vessel rupture by using semi-compliant balloon. This is just to remember you the difference between nominal pressure, rate burst pressure, between semi-compliant balloon on the left and non-compliant balloon on the right. Here you can increase up to 10% in diameter, while if you go from one pressure to another, you will more or less remain with the same diameter. So, coming back to our patient, balloon dilatation, 2.5 millimeter non-compliant, perhaps it's not the size we want, but I don't know from the distance whether you can see that there is still a ring there. There's still a waist. The balloon is not fully deployed. So what do we do now? Any proposal? Any proposal? Say it again. That's a good proposal. Bigger burr, that's also a good proposal. But bigger burr would mean that I have to, I can give it a try with 175 and a 6 French. It will be a lot of friction though. But what we did in this specific case, we gave it a try with cutting balloon. And look what happened here. This is a 3 millimeter and this is a 3.25 millimeter cutting balloons. Still the same ring. In addition, what we got on top is this dissection here. But the plaque, the lesion is beautifully there. It's still not opened. So what shall we do now? So the lesion is not fully modified, and we've got a dissection on top. Any proposal? This can happen to anyone, so we have to sort this out.
Presumably, if you've still got a significant waist, then you've got, in all certainty, you've got 270-degree arc of calcium or more. So
yeah.
It should therefore be amenable to IVL as long as you can deliver the balloon.
Right. That's a good option. You know,
I think you can upsize your burr, and if you're worried about the dissection, you can take another guide from an alternative access point, go from the leg for an 8 French guide in ping pong, Christos, I think I'd like some imaging to understand what's going on. The dissection shouldn't put us off doing more rotational atherectomy.
Yeah, actually, these are all fair considerations. Actually, you know, bigger bar is certainly an option. Either taking a new guiding catheter, why not, or just give it a try with a 175 within that one. Sometimes it can go. If there is concern about dissection, what we used to do sometimes is just pull everything off as soon as the flow is preserved. Put the patient on the CCU for 24 hours, observing him, and then perhaps discharging him and taking him back after 4 to 6 weeks. This has sometimes helped to seal the dissection and enabled us to do a more aggressive rotational atherectomy. But we have now, as some of you have mentioned, we have now this new tool that might nicely complement to rotational atherectomy in this case, as long as it can cross, of course. It can go through these lesions. And that is actually what we did. I mean, you all know how this works. Through electric sparks, it induces intimal fracture into the calcified layer of the vessel, and therefore should allow vessel compliance and optimization of the stent expansion. What we used in this case was a 312 shockwave balloon. We did two runs. This is at 4 atmosphere, and this is the final inflation at 6 atmosphere. Towards the end of this sine, you might perhaps notice that the balloon opens up a bit. This is the angiographic control after a shockwave balloon. There is some elastic recoil. We did some further balloon dilatation. This is now the 3-0 non-compliant balloon. You see that it opens up much better than it used to be before. And this is the final angiographic result after a 3.5 38 millimeter everolimus eluding stent. We did also a post-dilatation, of course, in this case. Case number 2, 72 years old patient, again presenting in March this year with an ACS no STEMI. This is the coronary angiogram. The right seems to be quite okay. On the left, you can already see where the problem is. There is a subocclusion of the mid-circumflex with some slow flow distally. You can also see, perhaps, if you look at here, the amount of calcium on the LAD as well, over there. Give you these other projections. Okay. So the colleague who was on call here went on and treated the lesion in the circumflex. So I show you this image. Apologies for the quality of the image. This was rather a big man. In this spider view, you see there's a lot of dark. But I think to those of you would not escape that this balloon is not fully deployed, right? I mean, there is also there a waste. Now, what would you do next in this case? What is your option? We have a balloon that is not fully deployed in the setting of an ACS non-STEMI. Any proposal?
So that was a standard balloon. You couldn't use an NC balloon.
There was a semi-compliant balloon, right? NC balloon.
I would take a smaller NC then. So you only need to release the calcium. So you could take a 2 millimeter non-compliant balloon and go to 26, 28 millimeters.
Yeah. Unfortunately, none of those was done because a stent was implanted. A 275 28 millimeter stent. I don't have the relevant still frame of the stent implantation, but you could see that there is a stent in there. You see the step down. At that point, my colleague realized that the stent was not fully expanded, and he tried a very aggressive pot with a 315 non-compliant balloon, but that was the result. Now, I think we all have few considerations about this kind of move. I think it's never a smart move to implant a stent in an undilated lesion. I think there is consensus there. Because stent thrombosis or restenosis can occur in this case. Having a stent there, that is even more important, I think it was alluded by you in the beginning, will not prevent vessel rupture in case of aggressive post-dilatation. And I just want to share with you one of the cases that I borrowed to one of my partners from Aalst. Of this case, you know, angiography shows us that there is some calcium, but this is a kind of patient we would do with regular balloon dilatation, and that was the case. Even stents were implanted at the level of the bifurcation there with no kind of plaque preparation at the proximal lesion there. Of course, the colleague was overconfident that he would manage like he did for the distal part of the lesion. And as a matter of fact, he was partially right. He managed to implant the stent, but in an attempt to optimize the stent, to fully expand the stent, he got this perforation. So those problems can still occur even if we have a stent already in place. When we had this problem in the past, before intravascular lithotripsy, the only option was to perform stent ablation. You know, this is not the kind of procedure, for those of you who have done this, where we are really happy to do it. We do it because we are forced to do it. And I share with you an historical case, I can call it like this, February 2016, when an elective PCI of the right was performed with this final result, which was far from being optimal. I don't know if you can see this nice under expansion of the stent, which resembles a bit the same stent result that we have got with our patient. The patient came back a few months after this procedure with recurrent angina, restenosis at that level, was done a lot of balloon dilatation there, even cutting balloon within the stent. OPN balloon, 3.512. You see this nice waist. And of course, it was ended up with the drug-eluting balloon with a suboptimal final result. In September of the same year, the patient came back again with recurrent angina and again restenosis at that level. This was the time we decided to do stent ablation, femoral approach, 7 French, temporary pacemaker. This is a 1.25 millimeter bar. I show you the way this bar progresses within this metallic part. Takes time. There you go. We paid a lot of respect to this segment because the last thing we wanted that the bar would get stuck in it. And in fact, if you notice at the very end, the bar crosses, but it entraps there, and without stop spinning, it was forcefully pulled back, and in this way, we got out of troubles. We hoped we made it, but actually it was not the case after the 125 millimeter balloon, as the non-compliant balloon dilatation was not yet able to open up this under-expanded segment. 1.5 millimeter bar eventually made the job, cracked the lesion with further balloon dilatation with this final angiographic result. So this was the case back in 2016. Coming back to our patient, we hope not to see this situation anymore. But we managed this under-expanded stent again with shockwave 312. Let's see if it moves. And also towards the end here, you will see at 6 atmosphere that the balloon opens up a little bit. When we perform further POT, you see now the balloon is much better expanded, leaving this result. We are not yet done. Don't forget the LAD in this patient. So we also have to treat that one. Now the shockwave balloon is open. Who would do shockwave in this vessel as well? Raise hands.
What do you mean it's open? You have a certain amount of...
Yeah. Are you confident that will cross? No. I would not do shockwave in this case. I've myself seen a live case of a patient where shockwave was forcefully pushed in this kind of situation, ending up in ugly complication upstream. So I think it's a beautiful device, it's a beautiful tool, but should be nicely used when it is mostly appropriate, and this is, I think, not the case. So what we did in this case was, again, rotational atherectomy, 1.5 millimeter bar. Please follow me in this rotational atherectomy, which is not that common. It's not the kind of procedure you do it every day. We wanted to do just one bar here. We started 1.5, hoping that we would make it. This is the first run. Normally, the first run is done really to probe the lesion, to touch like with a finger to see how tough it is. And then the real attempt is done at the second run. This is the second run here. Always back in motion. You see, never lose your patience, take your time. Third run, was still unable to cross. Let's see the third run. Little progress, but the bar doesn't cross yet. Okay, what to do next? I wasn't able to cross with this.
What size was this one?
Sorry?
This was 1.5.
This is 1.5. What would you?
1.25.
You would undersize? That's the consensus, undersize? Okay. What I did first, I was stubborn. I gave it a fourth and a fifth try. This is the fourth. Please notice also the speed of the packing motion, because that will tell you also how nervous the operator is becoming. Yeah? And this is the fifth run. No way, this bar doesn't go through. Do not forget that lesion had also a very annoying aneurysm. Yeah? So this kind of anatomy makes me nervous, because you can really have problem there. Okay, no way. This is the control angiogram after the several rounds. Actually, it's not, it's just door floor. I think the suggestion came from you. De-escalation, 125 millimeter bar. Okay, let's do that together. First run. Do you notice that now the packing motion has become faster? Okay, second run. You gotta be patient, huh? That is the bottom line of this case, be patient. Third run. There you go. And this is a polishing run. Okay. Of course, don't stop. You have 1.5 millimeter bar on the table. And you see, the plaque is still hard. Huh? It doesn't go smoothly, the 1.5 millimeter bar. Okay, but we did it. From now on, it has become a regular PCI, 3 and 3.5 non-compliant balloon, eventually opened up the stenosis. And this is the final angiographic result. I know you are thinking about this side branch, this bifurcation. My opinion is, if it's already so complex, don't mess it around with additional thing. The vessel is open. There is, okay, I agree with you. There's a tight stenosis, but this is as tight as it was in the beginning. I didn't make it worse. So if he stayed like this for many years, I'm sure he will be fine with this diagonal branch in the next years. If I still have 5 minutes, I want to share this last case, because I understood that Rota Pro is not yet available, if I'm correct. So it could be nice to share with you this new device from Boston. 81 years old patient, female this time, many risk factors, already underwent in 2005 PCI LAD. She presents with stable angina and mostly with dyspnea. ECG, not really helpful. Left ventricular angiogram. Overall preserved, perhaps some hypokinesia in the inferobasal wall. Right coronary angiogram. It's a non-selective injection. There is really a tight ostial lesion that you will see better in the next injection. This is the LAD. There's a mild lesion in the proximal segment there. And then you have a tight lesion in the circ. Okay, this was treated with balloon stent. With this result. Now we are left with this. Okay. This was our procedural setting and strategy. Femoral approach, 8 French guiding, 8 French arterial sheet, 7 French venous sheet, and we used in Judkins 7 French guiding catheter with sidles. We placed a temporary pacemaker. Now you have this angiogram done with the guiding catheter. Now the first problem here comes with the wiring technique. I mean, you are CTO experts. I don't have to tell you anything here. What I used in this case was a whisper extra support. I was just mingling around a bit, but then it eventually went in. Wire is positioned distally. I took in this time a Corsair. Yeah, place it distally there. Now the Corsair will come at a certain point here. Because of course the first thing to do is to put a rota wire down there if you want to do rotablation. Okay. This is the Corsair into the RPD. Exchange with the rota wire. This was the rota wire stiff that we use in this case. Okay, I spare you these images. Okay, good. This is what we are used to. This is what we have worked with for many years. The dinosaur, we can call it. Now it is called by Boston the legacy. Can you imagine? So what has changed now in the RotaPro as compared to the legacy system? The pedal, we got rid of the pedal. So it will be fun. The very first cases you will do, you will still keep pushing on the ground, but there will be no pedal left. The console has changed. It has become much more flashy and friendly user, giving you lots of feedback. So this is the new system. I'm sure you have seen it at meetings or at the booth of Boston. It has this new console that can be easily hanged on one of the pole on your cath lab table. It gives you this colored alarm. When it's red, it's bad, because it means that the bar is stalled. When it's yellow or green, it means it's almost bad. So be aware that your bar is about to stall. It gives you this triangle. When it's an empty or an open yellow triangle, it tells you that the speed has decelerated of more than 5,000 RPM. When the triangle is closed, it's more than 10,000 RPM. So it gives you this information. But again, when you are in the middle of the procedure, I bet you will be looking at those images if you don't have someone next to you who keeps attention to it. The advancer has changed as well. It has become nicer in a way. What the pedal did is just here now on the knob. There is a little button that activates the rotablator motion. The Dynaglide motion is activated by a button that is here. I'll show you in the next slide. To switch between rotablator mode and Dynaglide mode, you have to push on this other button here. So everything is on the advancer, on the table. This is here the Dynaglide activator button, and this is the switch between the rotablator mode and the Dynaglide mode. Okay. Oops. How can I stop this? Okay.
The speed is 161. It's fine.
Okay.
Now I check the
Stop.
Dynaglide.
Stop. Okay. How can I close the audio? It doesn't. There you go. Okay. I show you again. Okay, he wants to talk. What's nice is that it comes with a speed that is preset at 160.
It's fine. Now I check
The Dynaglide mode.
Dynaglide mode.
You push there.
This.
Yeah, and then dilatated mode, okay. And then you have 75,000, voila, 73,000 RPM. And then you just go on in the way you like, either with one operator or two operators, whatever you like. Okay, this is not really interesting. Let's come back now to our patient. This is, like with any other aortosteal lesion, we like to go with bigger bar than 125 millimeter in order to prevent that the bar would slip in without fully ablating the osteal lesion. We started with a 1.5 millimeter bar. Very quickly, this is the plaque modification. Of course, you have to start from within the guiding catheter because there's no other option. Try to get your guiding catheter coaxial. First and second run with a 1.5 millimeter bar. This is the angio control. Of course, you will see all this accordion effect. It all disappears. It is also due to the fact that we have now an extra stiff rota wire. Polishing run. Okay. It is extremely important to keep the guiding catheter coaxial because that can cause bar entrapment otherwise. Okay, then it becomes an easy PCI, balloon, balloon, and then cutting balloon as well. Big stent, post-dilated, and show you the final angiographic result. In the same document, we also made some recommendation as it pertains to osteal lesion, but we just discussed them now. Management of complications. We can be here other 30 minutes, but I don't want to waste your time. This algorithm has been already mentioned before. I show you this slightly adapted algorithm here from Richard Schlofmitz, where we have put into the equation also the depth of calcification. Christos has alluded to it before. And where might be the place of each of the techniques currently available to treat the calcified lesion. So nodular superficial, it will be more for rotational atherectomy. I don't put the orbital atherectomy because we don't have it. While for deep calcification, non-compliant cutting or scoring balloons and intravascular lithotripsy, especially in proximal segments, because as soon as we have segments that are not proximal, all these devices on the left might have troubles to travel into the coronary artery. And I want to close by advertising this new initiative, the Euro 4C, Andreas has mentioned in the beginning. It's a group of colleagues passionate in this topic. So if you're interested to join in being informed in all our initiatives, just surf on this website, register your name, your email will provide you with information about our activities. So if you want, I can give you the link later on. And these are my conclusions. So optimal treatment of calcified stenosis requires patience. I think this is the first bottom line. An adequate plaque modification. Cutting or scoring balloons are suitable for proximal, focal, and not tight stenosis. Intravascular lithotripsy is a novel option, especially in deep calcification and proximal and not tight stenosis. We have heard in the beginning calcified nodules, big arteries. That is not the place for rotational atherectomy. Rotablation would really do nothing in these cases. Perhaps intravascular lithotripsy, but we need more data there, might be the solution. Rotablation is recommended for preparation of heavily calcified or severely fibrotic lesion that cannot be crossed by balloon or adequately dilated before planned stenting. Thank you very much.